I'm excited to be able to join everybody today, at least virtually, at the 2020 Canadian Ophthalmology Society virtual annual meeting. It seemed like it was just yesterday. I was actually in Montreal at the Canadian Ophthalmology Society meeting. I think that was back in 2013. So I do look forward to joining my colleagues north of the border in person soon someday. But for now, we'll be meeting virtually. So I'm excited to talk today about the TECNIS Synergy IOL, the newest member of the TECNIS family of presbyopia-correcting lenses. Now, to understand the Synergy, it's not just a single product by itself, but it does belong to the entire TECNIS family of lenses. You're familiar with the TECNIS Symphony, the TECNIS Multifocals, the TECNIS iHance, which will be available in Canada soon, of course, the TECNIS monofocal platform, all built on a similar technology of great materials and great design. So I'm going to tell that entire story, then share some specifics with the TECNIS Synergy. We do not quite have FDA approval in the US, although I have been an investigator in the pre-market approval study and also the proof of concept study. So I do have some hands-on experience of which I'd love to share, as well as the kind of technical background and story around the TECNIS Synergy lens. So this is just a disclosure slide. It says J&J does not engage in the practice of medicine. I'm going to share views that are my own. So my career goal, and I always like to start my presentations this way, is my career goal is to conquer presbyopia. So to be able to help patients see better without the bifocals or reading glasses for up close. And it's a pretty ambitious goal. I still kind of joke and laugh a little bit when I say this. I thought about this when I first started 10 or 15 years ago because it's this audacious goal, but it's fun going through this journey. And of course, the TECNIS Synergy IOL is the next step in what we can do. And what I've learned is it all starts with quality vision. Because the whole reason that we do cataract surgery, the whole reason we take a lens out is we're trying to improve the quality of vision. So we need to always focus on that regardless of what we do from a range of vision standpoint. We need to give good, sharp, and clear vision. So the first question I want to ask though is, why do we need to conquer presbyopia? Why is that a big deal? Well, the typical view of presbyopia is that as patients pass age 40, they have trouble seeing at near. And actually, when I first started talking about this, it was a they. Now it's kind of like as we pass 40, I won't disclose my exact age, but we start having a little trouble at near. So we just prescribe some bifocal glasses and they'll be fine, or we can implant a presbyopia-correcting lens, but patients may want to have some unwanted side effects. So the whole idea is with cataract surgery, though, presbyopia treatment is not optional. So we're going to weigh the risks and benefits like any surgery of presbyopia correction. And we can either correct it surgically or patient will have some sort of correction with glasses. So when we think about the risks and benefits of a surgical correction of presbyopia, we have to think of the alternative as the risk and benefits of using glasses. In particular, with bifocal glasses, there's an increased risk of falling. When I say bifocal, really it's a multifocal glasses, whether bifocal, trifocal, progressive ad lenses. The studies have shown that there is more than twofold greater likelihood, about a 2.3 times greater likelihood of tripping and falling in the elderly patient population who wear bifocal glasses. So 1 in 3 falls, greater than 1 in 3 falls can be attributed to bifocal glasses. Now, to put it into context, in the US in 2014, there were 29 million falls, 800,000 of which resulted in hospitalizations and over 27,000 deaths. Now, to compare that to prostate cancer and breast cancer in the same age group, there were more elderly Americans who died of falls than of those two cancers. So certainly it's a huge deal. And if greater than 1 in 3 of these are related to bifocal glasses, you can extrapolate how many falls and hospitalizations and even deaths could have been caused or somehow attributed to bifocal glasses. And for those who aren't injured, greater than 1 in 3 or about 1 in 3 falls result in this concept of a post-fall anxiety syndrome. So the total cost of the fall injuries in the US in 2014 was $31 billion. So again, that's, if 1 in 3 of these falls related to bifocal glasses, that's a significant amount of money. Now, the good news is that first eye cataract surgery reduces the fall rate by 1/3. So there's somebody who didn't fall. And studies have also shown that by replacing the bifocal glasses with single vision glasses, you can actually reduce falls by up to 40%. So it does make a lot of sense. It correlates that that 1 in 3 falls are related to bifocal glasses. So again, when we're thinking about why should we conquer presbyopia, why should we care about addressing presbyopia during cataract surgery? Well, when you really weigh the benefits and risks of a presbyopia-correcting lens versus glasses, glasses and bifocal glasses in particular can have some significant risks that we haven't really paid attention to. So just something to think about as we move forward. So the question is, could the surgical correction of presbyopia actually maybe be the safer option? May not always be the most convenient option for the surgeon having to deal with some of the issues with these lenses. There's always a trade-off here, but it can have some better safety benefits for the patient. Okay, so when I talk about presbyopia correction, I like to think about a balance of 3 interrelated concepts. One is visual quality, depth of field, and dysphotopsias. So the goal of presbyopia correction is to increase that depth of field. And whenever we do that, we're going to lose some visual quality potentially and increase dysphotopsias, specifically low light or nighttime vision dysphotopsias. So the goal is, again, as I said earlier, we want to maximize the visual quality, and the way we do that is by minimizing optical aberrations. So to maximize visual quality, a lens must have great optics, has to be precisely positioned, and it has to stay there. And we need to do in that order because it all starts with optics. Right, we have to get the optics right to focus the light right. As I said, as we remove the lens and put an implant, the whole goal is to have the best quality of vision, the best quality of optics possible. And for optics, it starts with material. So the actual material that the lens is made of, the index of refraction, the chromatic aberration or dispersion characteristics, that's your starting point. You want to have a great design, correcting other aberrations, obviously both an optic and a haptic design. And the manufacturing process is translating that design into reality. It has to be done with good precision, reproducibility, and of course, quality. So every IOL in the TECNIS family has foundational material, design, and manufacturing technology. So whenever you pick up a TECNIS lens of any sort, whether it's a one-piece monofocal, an extended depth of focus, a hybrid lens like the Synergy, a toric lens, you know you're based on all these principles. So when I talk about optics, I always like to throw out this slide. You know, when I first started this journey, I realized as a professional surgeon, I knew less about the optics of my lenses than most amateur photographers know about theirs. You know, it's kind of a shame because amateur photographers who spend time looking for lenses and shopping and take pictures and looking into the effects really spend a lot of time. As surgeons, you know, the rep comes in, we try a new lens, patient's happy, and great, we're happy. So we don't quite get that direct feedback that a photographer would. But given that we're doing this professionally, it behooves us to really understand what we're putting in the eyes and how that makes a difference. So the 2 primary optical principles that come into effect from visual quality, and you may have heard these before, is number 1, spherical aberration, and number 2, chromatic aberration. And spherical aberration has to do with the focusing of the central and the peripheral rays don't quite focus the same. Chromatic aberration has to do with the different wavelengths or colors of light that breaks down because of the change in the index of refraction based on color, so the different colors don't focus together. So the IOL material and design is going to affect the optical quality because of these 2 quantities. So the goal, again, is to minimize the aberrations to maximize the optical quality. So let's first talk about spherical aberration. So we know that both the cornea and the lens induces spherical aberration in the eye. Typically, the cornea has positive spherical aberration, so the population average is positive. The lens is negative, and therefore the net total is close to 0. So a young, healthy eye tends to have little net spherical aberration. We do know as lenses age, the spherical aberration increases, so you start to get positive net spherical aberration, and that can cause visual quality. Even in a dysfunctional lens before we develop cataracts, sometimes the visual quality is not quite there because of the spherical aberration changes. I sometimes wonder myself when I'm in kind of a dimly lit room, I think I can't see as good as I used to. So given that I'm in my later 40s, am I having dysfunctional lens? Maybe I'm not remembering that. Maybe I'm just being paranoid, but that's the process as we lose visual quality. So the idea of correcting corneal spherical aberration is we can improve visual quality that way, or image quality. So spherical aberration reduction equals contrast sensitivity increase. And only the TECNIS lenses corrects the full spherical aberration of the population average cornea. So again, sharper quality of vision, enhanced functional vision and safety. These are all 20/20s. They're all sharp, you can see it. But clearly, as you move from the left to the right, is the quality of the E, the contrast increases. And that's important because we look at an eye chart That's 100% contrast. We have great lighting conditions, but the real world only goes down from there. There's color, there's blur, maybe the lighting's not right, contrast is decreased. So there's a lot of things that patients are struggling with. What the patient sees in your exam chair is the best they're ever going to see. The real world is just a difficult situation. So you want to give them the best quality, in particular contrast, possible. And interestingly, in a simulated driving study, the increased visibility distance at 55 miles an hour improved the reaction time by about half a second, which correlates to about 45 feet advantage of braking room. So identifying a pedestrian hazard, it reduced that reaction time so that in theory, there'd be less of a chance that someone gets hit. Now you compare that to the center high mounted stop lamp. There were some studies done in the US back in the 1980s that showed that the third stoplight there improved reaction time from 0.09 to 0.35 seconds. So not even as much as what the TECNIS correction of spherical aberration did. Yet the US government made that a mandated component of cars back in 1986. So by correcting spherical aberration, definitely a quantitative increase in quality of vision, reaction time, and potentially safety there as well. So again, spherical aberration, we're correcting what's in the cornea. So the cornea can be positive, it could be minus, maybe like in a hyperopic patient, so it's not always necessarily the best thing. But the idea with the TECNIS lenses is it's average for the, it corrects the spherical aberration of the population average. So if you had to pick a lens and use it for everyone, that's the best lens. Now with chromatic aberration, it's a similar concept, but fundamentally a little bit different. Corneal chromatic aberration is similar in all eyes, and the idea is you want to minimize the additional amount of chromatic aberration that you're adding to every eye. So while spherical aberration was half of the visual quality story, I think it was actually the smaller half. It was the half we heard first, but when you look at other optical fields, chromatic aberration always seems to be the bigger issue. So let's talk about chromatic aberration. The cornea and the lens both have chromatic aberration. So the blue light bends more than the red for the cornea, does the same thing for the lens, and of course for the eye, it's additive. So we get this concept of dispersion. So the difference between the red or the long wavelength light and the blue or violet and the short wavelengths of light is measured in this concept of dispersion. So when you change the natural lens for an IOL, it has a certain amount of dispersion. So IOLs have chromatic aberration as well. And depending on the material, specifically the dispersion level of the lens, so if you have a mid-index refractive index, low dispersion material like the TECNIS material, there's a small amount of chromatic aberration, probably comparable to the human lens, maybe a little less, versus a high index, high dispersion material like the Acrosoft material, where you actually have more or a higher chromatic aberration. You're going to have different amounts of dispersion in the eye. So we can talk about Abbey numbers, but I like to think about dispersion in terms of diopters. So the difference between the red and the violet light between 700 and 400 nanometers of light, how much refractive difference is there? So if you look at a graph, looking at the chromatic or refractive difference between 700 and 400 nanometers with different lens materials, first of all, the cornea is going to contribute about 1.7 diopters. So when you remove the lens, you take out the natural lens's chromatic aberration, but when you add a lens implant back in or an IOL, you're going to add more chromatic aberration. And depending on the material, starting from the highest Abbey number or the lowest dispersion material, which is the TECNIS acrylic, you're only adding in about half a diopter of chromatic aberration compared to the highest dispersion, lowest Abbey material, the Acrosoft material, nearly threefold greater, 1.28 diopters of chromatic aberration that you're putting back in the system. So there's nearly 3 diopters of chromatic aberration for the entire eye. So it's a huge difference based solely on the material of the lens of what the chromatic aberration for that eye will be. So what does this mean? So if you look at, let's say a lens here, we'll pretend like they're prisms. So you have a mid-index, low dispersion material at top, a high index, high dispersion material on the bottom. When you put light through it, white light through it, it gets spread out. So you have a certain amount of chromatic aberration. So if you have low dispersion, you have a nice sharp image here. Whereas if you have high dispersion, the colors kind of separate out and you get some chromatic aberration banding. Now, just for you technical folks who are thinking about this, what I'm demonstrating in the picture is a transverse chromatic aberration versus what's really happening in the eye is more of a longitudinal. It's harder to show in a picture, but the concept is the same. So imagine if you have a high dispersion material and you start adding diffractive properties to it, where you're going to end up with a kind of waxy type vision. And we had that early on in diffractive lenses because we had some issues with waxy vision. Now, higher ordered monochromatic aberrations like spherical aberration can play a role, but chromatic aberration certainly can contribute to that as well. So how do you improve that without changing your material? Because if you lower your dispersion, you're going to have to lower your index. Well, one thing that potentially can make a difference is adding a chromophore. So the idea is by blocking out the out of focus light, the violet and the blue, maybe you can improve the quality of image. And we do know that's happened historically in some higher dispersion materials, although the studies haven't shown any real difference that it's made. But the idea is you want a material with low dispersion. You want to start with good chromatic aberration properties. You want to start with a good material so you don't have to kind of make up for it by using chromophores. Now, you don't need a chromophore to filter chromatic aberration. However, and I'll talk to you later on in this talk, is sometimes having a chromophore can be helpful in other ways. But from a visual quality standpoint, from an optics standpoint, the most important thing is not to have the chromophore, but to have the best material with mid-index, low dispersion, best focus will give you the best image quality possible. So everything I've been talking about so far is refractive optics. So blue light bends more than red, so you have a certain amount of chromatic aberration that's put into the system. You want to put in as little as possible, but every lens you put in is going to add to the chromatic aberration. Now, interestingly, diffractive optics actually reverses that. So in diffractive optics, the red bends more than the blue, so when you use diffractive optics, potentially you can correct the chromatic aberration that's on the cornea, much like using negative spherical aberration lenses can correct the positive spherical aberration of the cornea. Similarly, with chromatic aberration, you can convert and correct the blue bends more than red. Now, the neat thing about chromatic aberration is every cornea is the same. So every time you put a diffractive optic lens, you can actually cancel out consistently the chromatic aberration of the cornea. So let's take a look at this. Similar graph as before with the amount of chromatic aberrations in diopters. You look at the Acrosoft material, nearly 3 diopters of chromatic aberration. You look at the Restore lens. We've looked at this for various Restores. Panoptics will probably be the same without any diffractive light. For the far focal point, same amount of chromatic aberration. If you look at the TECNIS one-piece lens, already much less chromatic aberration to begin with at 2.16 diopters. And with the TECNIS Symphony, you're actually going to correct that. So you reduce the amount of chromatic aberration that even the cornea has to a level that the patient has never actually seen in their life because they have less chromatic aberration with the TECNIS Symphony lens than even a young, healthy, quote unquote, healthy eye, because we're actually correcting the chromatic aberration of the cornea. Now, some of that correction is being used for that extending the depth of focus. Some of the clarities is being used for that because the eye kind of has a theoretical maximum of image quality. So we want to maximize that, utilize that for trying to correct presbyopia. Now, if you look at the TECNIS Synergy, which I'm going to talk a little bit more about later, is it does that even more. The Symphony reduces the amount of chromatic aberration of the eye. The Synergy even reduces more than what the TECNIS Symphony does. You'll find the overall chromatic aberration is even lower with the Synergy, which is fantastic because we're going to extend that range even more using a hybrid technology, and that chromatic aberration or the chromoline technology becomes very important. So again, to have outstanding optics, we need to correct spherical aberration, we need to correct or minimize and or correct chromatic aberrations. The material and design affect optical quality, and of course, minimizing those aberrations will maximize the optical quality. So how do you compare optical quality? Now, as I alluded to earlier, we typically implant a lens in a patient, they're coming in with a cataract, they're happy. If it's a monofocal, pretty much whatever you put in. If you put a diffractive lens, multifocal, EDOF, or even a trifocal, then it's going to be a little bit harder to compare. Now, there's some studies that show that. We try to do that. But the easiest way to compare quantitatively is on a bench. Now, you have to be careful when it comes to an eye bench because the ISO standards, which are needed from regulatory standpoint, specifically say they don't represent reality. So you want to create a model that represents reality as close as possible. So J&J, back in the AMO days when they developed the TECNIS, developed what's called the average corneal eye model. So what that did was it incorporated the average corneal spherical aberration. They also use white light, which takes a look at the chromatic aberration. And they look at both 3 and 5 millimeter pupils, which affects basically takes into account the pupil lighting conditions. So if you ever see a benchtop test that uses green light, you know that chromatic aberration is not being addressed, and probably the lenses being tested have poor dispersion properties. So always look for the white light, always look for the full spherical aberration. So in this case, the y-axis is MTF, or modulation transfer function, which is basically an indication of just image quality. The x-axis are different lenses. I'm going to group these. We have monofocal lenses on the left, multifocal or really bifocal lenses here in the middle, trifocal lenses, EDOF, which is Symphony, and I'll call Synergy a combo lens. So in bright light with the smaller pupil, you're going to have better image quality. The TECNIS has an MTF of 0.57. The Sensar without the spherical aberration correction, but with good chromatic aberration dispersion material, is 0.47. The Acrosoft IQ lens, which has poor chromatic aberration with some spherical aberration, is okay at 0.49. Now, when you go to a multifocal, you're going to lose image quality. So you get into the 0.3 range. Similar with trifocals, the TMF has close to the best at 0.32. The Restore, the Panoptics, the other trifocals in the 0.26 range. Now, interestingly, the ISO standard, so it's a slightly different one, but they require 0.25 for monofocals. It doesn't quite apply to these presbyopia-correcting lenses, but when you get in the 0.2 ranges, you start to be concerned about image quality. Now, Symphony, one of the great things about it was because of the correction of chromatic aberration, was able to maintain an MTF in bright light of 0.44. And the Synergy, because of the greater range, even with more chromatic aberration correction, is actually giving you the highest MTF of any multifocal or trifocal lens. Not quite as high as Symphony, but a pretty good quality of image. Now, what happens when you go from a 3mm pupil to a 5mm pupil? You're going to have more peripheral cornea coming in, or light coming through peripheral cornea, more spherical aberration. So the image quality is going to decline for everybody. So there's Symphony, Synergy. Symphony gives monofocal level vision. So when the pupil gets larger, there's a decline or a drop in image quality. Now, interestingly, what you note is for the Symphony, the drop is very small. And with the TECNIS Synergy, there's actually an increase of image quality when you go from bright to dim light. So as far as I know, this is the only lens I know of that you actually get better image quality when the pupil is bigger. So in theory, in dim light. Now, of course, it's harder to see when there's not as much light, so it's still going to be more difficult, but at least the focusing and the image quality that's produced is going to be better. Now, again, if you look at where the monofocals are, so 0.37 for the TECNIS Synergy is comparable to 0.4 of the TECNIS monofocal lens in dim light, which is actually higher. Both the Symphony and the Synergy have a higher MTF at 5mm than even the Acrosoft IQ lens, and that's because you're correcting the spherical aberration, is because you're minimizing and even correcting to varying degrees the chromatic aberration of the eye. So while diffractive optics and extending the range of vision can cause some image quality, simply having aberrations, spherical chromatic aberration, can really degrade image quality. And if you don't correct it, like the trifocal lenses, you're going to really have issues when you start to come into both bright light, but even in dim, especially in dim light. So again, that's the story of optics. This is why I'm going to kind of let the cat out of the bag. This is why I put the TECNIS Symphony in my mom when I did her cataract surgery several years ago. Okay, so a pupil independent design. So again, from 3mm to 5mm, you notice that the TECNIS Synergy maintains that modulation transfer function quality right around the mid-point 3 ranges, 3.4, 3.7. Whereas the trifocals, they do okay in bright light, but they really fall off in dim light. So in terms of being able to see clearly with quality in dim light, that's going to be an issue for all the trifocals. So again, we're balancing these three things. The whole goal is to increase the depth of field. We need to maximize visual quality. With multifocals, with trifocals, we're going to reduce image quality with that increased depth of field and dysphotopsias. With EDOFs, we have a different balance. With the Symphony, by correcting the chromatic aberration, we can have visual quality similar to monofocals. And I would say with the Synergy, which again is a hybrid lens that has multifocal and EDOF components, we have visual quality that's better than a lot of the multifocals and trifocals on the market. So that's visual quality. And of course, depth of field, the idea is we want to take that visual quality and have it over a range. So these are related. I'm going to move to some defocus curves. And if you're not familiar with a defocus curve, the y-axis is the image quality or the visual quality. And the x-axis is the diopters of defocus. So 0, which is optical infinity, is distance. And as you get nearer, for a monofocal lens, the image quality drops off. Now, multifocals, very familiar graphs. Depending on the add power, you can have a focal point at either 33, 40, or 50 centimeters for a TECNIS multifocal 4, 325, and 275. So you have great distance vision, a little drop off in intermediate, which isn't too bad, 20, 25 here, and a peak again at near. So depending on the multifocal, you can have those different focal points. Fantastic lenses. I love to use them, particularly for patients who are myopic and want better near vision. It's a good balance to have. In the US, we have the multifocals and just the Symphonies, not the Synergy yet. Now you look at what the Symphony did as an extended depth of focus lens. There wasn't a second inflection. Basically, the idea is that the amount of focus at 2032 is increased by at least half a diopter by definition. The Symphony does it by over a diopter. So you have the strictly monotonic decline. You don't have that second peak, but you do have a broader range of vision. The TECNIS Synergy lens, again, we don't have US PMA data or FDA data yet, but I did present a poster at ESCRS in Paris in 2019. I'm going to share the results of that poster. It's basically a visual outcomes and defocus curve profile of a next-gen diffractive presbyopia-correcting lens in collaboration. This was the proof of concept study that J&J did a couple years ago. So the idea is we want good image quality, range of vision. That's what I've been alluding to this entire talk. You look at, again, the MTF data. This is what I showed earlier compared to the trifocals at 5 millimeters. It's fantastic, even better than the TECNIS multifocal and comparable to a TECNIS monofocal because of that correction of chromatic aberration. Simulated defocus curves show that the TECNIS Synergy here in red is going to give better range by at least half a diopter over every trifocal on the market and a better intermediate range than every trifocal on the market as well. So that's pretty high bar that was set by the design team. So basically we did a multifocal randomized bilateral 6-month study comparing the TECNIS Synergy, the test lens, against the TECNIS 3.25 multifocal, which is a fantastic multifocal lens as a control. The key parameters were distance-corrected defocus curve, which pretty much tells the whole story. Distance-corrected intermediate vision at 66 centimeters and near vision at 40 centimeters. Those 12 US sites, we enrolled about 150 subjects. Well, these are the results for about 150 subjects. Roughly 75 in each group. So the monocular defocus performance, again, this is monocular at 1 month. So you can imagine binocular at 6 months will be even better. You look at distance, only about a 2-letter difference between the Synergy and the multifocal control. You look at near, at kind of the sweet spot at 40 centimeters, very similar, but the key is there's a 1.5 line gain of the TECNIS Synergy at 66 centimeters compared to the TMF. There's a half line gain or 0.6 and 0.4 line gain at a meter at 50 centimeters. And then you look at 33 centimeters, so when you get to really near vision, there's a 0.7 line gain. And really, this continues to extend all the way down vision to 30 and even 25 centimeters. You still have 20/40 vision. So in summary, with the binocular defocus performance, distance corrected at 6 months, so this is both eyes at 6 months, 2020, the vision was greater than 1.0. So better than 2020, best, of course, corrected in a defocus curve situation, best corrected distance vision. There was 2025 or better vision from 0 all the way to -3 or 33 centimeters. So from optical infinity to 33 centimeters, at least 2025, and mostly better vision. And if you look at this, so even with up to half a diopter residual hyperopia, you're still going to get 2025 vision to the 40 centimeter reading range. So this is really amazing near vision. So near vision is maintained down to 33 centimeters. This is, in my experience, like TMF +4 near vision. So many of us haven't used the +4 real consistently in a while, but that gave fantastic near vision. The difficulty was the intermediate vision dropped off to 20/40, but with the TECNIS Synergy, it does provide that full range of vision. When I talk to these patients, I asked them where the sweet spot was. There wasn't really a sweet spot. They could just read wherever they wanted to. They held the card up close, really close. Some people were holding at 12 inches. They would push it out and they wouldn't really notice a difference. So the nice thing is with the TECNIS Synergy lenses, patients aren't hunting for that range. You don't have to say, oh, what kind of activities do you like? I want to put it in this lens or do that. They really give a nice full range of vision. From a strict visual acuity standpoint, the intermediate and near vision at 1 and 6 months. For the Synergy compared to the multifocal control, visual acuity logMAR is about 0.1 or about 20/25 at near. And intermediate, it was about 20/25 or so, whereas the multifocal control dropped to about 20/30, which is about 0.2 logMAR. So there's about a 1.2, 1.3 line improvement in intermediate. But again, the idea with the Synergy is when you look at the single points at 40 and 66 centimeters, doesn't tell the whole story. The defocus curve showed that we achieved 20/25 acuity, both at 40 and 66, but also at higher at 100 or at a meter, and also down to 33, even 25 centimeters. So looking at best corrected distance vision, intermediate vision, and near vision, FAR had excellent, better than 20/20 vision. Intermediate, there was about a line gain compared to multifocal, and at near, there was no statistical difference. So again, even though the DC near vision, the distance corrected near vision at 40 centimeters is comparable, expect better reading range with the TECNIS Synergy. They're not hunting for their vision. They just hold a book or the material they're trying to look at wherever they want to. So in summary, the TECNIS Synergy maintains excellent visual acuity through 3 diopters of defocus. There's a 1.2 to 1.3 line gain at intermediate. There's a range exceeding that of a multifocal control while providing better distance vision, or distance vision better than 20/20. So again, excellent range of vision, and the defocus curve shows that you can fully optimize far vision and still achieve full range vision from far through near. Now, one thing I'm just going to point out, since I do have the defocus curve slide here on here, is the left side of the defocus curve, which we usually don't pay attention to, which is the hyperopic vision. So if you aim a little minus with this, it does drop off slightly faster than lenses that we're used to. So the recommendation is to aim actually first plus with the TECNIS Synergy lens. This is the, there's been discussion in the past of aiming plus for some multifocals to minimize the halo effect, because it'll be a little bit displaced from the retina. You're essentially reducing the add power and making the halo a little smaller. Well, in this case, we don't need to aim minus to give better near vision. Even if you end up just a little bit plus, you're still going to get fantastic distance vision and amazing near vision. So the general recommendations, if you're using this, is to aim first plus as opposed to first minus. So you'll have plenty of near vision to go. Okay, so that was the results from the PMA study that I presented at ESCRS in Paris. That's very promising and very exciting. Now, I'm going to move on from visual acuity and depth of field and tie that into dysphotopsias, because that's what probably everybody's thinking about is, what about the night vision symptoms? So before I really talk about dysphotopsias, I'm going to talk about kind of the concept of dysphotopsias, because we roll these words off our tongue, glare and halos, starburst, but sometimes we don't really know what they mean. So I want to kind of talk a little bit about that. So glare is basically when a point source of light is out of focus, so there's a blur around there. Halo is when there's a distinct circle of light around that point source of light. And a starburst is when there's little lines coming out, or little pins of light that comes out. That's a starburst. Now, those are the terms that the FDA uses. That's what we use in all of our studies. Of course, halos can take on different forms. You can have multiple little rings. You can have mixtures of different types of dysphotopsias. You can blend halos and starbursts together. So to really understand, to counsel the patient, you need to understand what these lenses are doing. So from a conceptual standpoint, let's take a look at this kind of model of the eye. So if you have a plano eye with a monofocal lens or accommodating natural lens, you have a point source of light, it all focuses to one single point. So what happens if that eye is myopic? Let's say in a -2 situation, all the light focuses in front of the retina, so there's a blur here, or blur circle on the retina. So you get essentially some glare, maybe a little starbursting from some of the pupil edges and other aberrations. So that's what happens from the image. So when you're out of focus, you're not focusing your far focal point in the retina, you're going to get light that's off axis. So if you plot this on a defocus curve, you look at the monofocal at distance, at plano, you're going to have a nice point source of light. So if you have a myopic eye, let's say a -2, it's going to look like this, the top picture. And if I reduce the myopia, as the defocus curve slides over to the left, you notice the off-axis light goes down. So we go the other way, you increase the myopia, there's more light off-axis. That explains why you have symptoms around lights. Now, if you take that same concept and you plot a multifocal, you have a hump for distance and a second peak at near. So essentially you have energy that gives you that distance center. The intermediate has relatively less energy, so it's a relatively dim zone. Of course, this is an exaggerated image of a halo. And then the near vision, there's more energy there again, so hence a bright, dim, and bright zone, and that's why you have a halo. Now, again, applying this concept, the size of the halo is going to be related to the add power, and the intensity of the halo will be related to how clear the vision is or how much energy you're distributing to that focal point. So applying this to the TMF series of lenses, the TMF plus 4, we know, has the biggest halo, gives the best near vision at 33 centimeters. The TMF 325, the halos are a little smaller, and the 275 even smaller. When we did the US FDA PMA study for the TMF low ads, or the 325 and the 275, we found that 6 months that there was actually fewer patients with trouble with night vision with the TMF 2.75 multifocal than the TMF monofocal. They had less trouble with night vision, even though they technically had more halos. They enjoyed that near vision. So the nice thing is, as the halos get smaller, they tended not to block the cars. They weren't dimmer, but they just weren't in the way of what the patients needed to see, so they were able to tolerate that better. Similar concept applies to Symphony. Without that second peak, I wouldn't expect a primary halo. So in theory, you're going to have night vision symptoms similar to monofocals, and that's what we initially heard. That was the initial understanding. But as it turns out, there are kind of some, I would call them higher order other effects that in reality we know the Symphony does cause a slightly different type of pattern. So the important thing is that when we understand these lenses and we describe to patients what exactly type of night vision symptoms you have. So for example, a single halo, mostly with maybe a little star bursting, is what a multifocal would look like, versus the Symphony lens, at least based on my description, talking to colleagues, talking to lots of patients, is they get multiple fine halos and little starbursts or little lines that come out from the light. I tell patients it's going to look like a little spider web that's glowing in front of the car headlights, and that's a very descriptive, it's a descriptive description, and the patients seem to understand that. And when they see it, for most of them, doesn't bother them. I say, hey, you look away from the light, focus on the roads. Most people do just fine. But if you just say you're going to have glaring halos, the patient has no idea what you mean. And when they see these little lines coming from the lights, they say, hey, you didn't tell me you're going to have these lines. But if you say you're going to have starbursts, and I show them you have little lines, it's going to be fine. And then when I see them post-operatively, I ask them day one. A lot of them haven't seen it yet, and then I bring them back in a week. And by that time, most patients are like, oh yeah, I see it. It doesn't bother me. You told me they'd be there. They're there. I know the lens is working. So describing that is very important. So the Symphony, in my experience, had less night vision symptoms. They were different. So if you don't describe them right, the patient's not going to be happy. But if you describe them correctly, I feel like they were less than, especially the higher ad multifocals. The Synergy, as you can imagine, with more near vision for that broader range, you're going to have more off-axis light. So you're going to have more starbursts, halos, glare compared to the Symphony. Now, there's some changes that were made that I'll get to shortly that's going to reduce that and improve that some. But the fact is, when you talk to these patients, if you're expecting to give near vision with any kind of lens, trifocal, you're going to have some night vision symptoms. The important thing is you describe it to them and prepare them for it. And again, most of them do just fine. So when I talk to my patients, I did a couple of studies with the proof of concept and also the US FDA study. Patients were fine. No one really complained about them. They said they saw them, but they were able to function and do well with them. So one thing we know about dysphotopsia is that higher energy, shorter wavelength light has a greater tendency to scatter. You know, from Rayleigh scattering, that's when the light's coming through the atmosphere of water molecules, gives us the blue color in the atmosphere, because the blue, which is the shorter wavelength, tends to scatter more. So when you look at a lens, filtering the high energy, shorter wavelength light can reduce the amount of scatter. Now, an interesting study that was done several years ago is looking at the TECNIS material. This is in a monofocal study where we showed improved daytime and nighttime driving. So basically the difficulty or the ease in driving using a clear, this is a TECNIS monofocal versus a OptoBlue or one with a violet light filter, was significantly improved both in daytime and especially in nighttime. So by simply filtering out some of the shorter wavelength violet light, and I'll tell you about, and I'll show the difference in the curves here soon, is by filtering out the violet light, you can improve ease of driving, even in monofocal patients. And again, for some theoretical studies show that reducing the halo intensity of a light source, let's say the iPhone in photopic light versus xenon headlights in scotopic or low lighting conditions by 13 up to 29%. So simply filtering out the shorter wavelength light, again, we don't really need to improve the visual quality from a chromatic aberration standpoint because the TECNIS material is so good, but the night vision symptoms, the scatter, the nighttime dysphotopsia can be improved with a violet light filter. And that's added, of course, in the TECNIS Synergy lens. So when you see a lens, or you put a Synergy in, it's going to have it's been described as a champagne kind of color. It's not a bright yellow glow, but there's just a slight hint of a yellow that filters out violet and lets all the blue light in. So let's talk briefly about lights and colors. Okay, so light, again, in general is about 400 to 700. The eye can actually detect down to about 350 or I'm sorry, about 380 or so wavelengths, nanometers of wavelength. So from 380 to 450, that's considered violet. From 450 to about 500 nanometers, that's considered blue. And from 500 to 570, that's considered green. Those are the ISO standards of color characterization. Now, there's there's several issues that we need to take into account when we're thinking about violet light filtration. Number one is visual quality and function issues. Number two is phototoxicity. So high energy light can cause phototoxicity. And number three is a circadian rhythm concern. So visual quality and function has some subcategories. Number one is light scatter, as we talked about. Two is chromatic aberration, as I've alluded to earlier. And three is scotopic vision, or the quality of vision in low light conditions. And then, so basically there's visual quality and function has several subcategories. Phototoxicity, high energy light can cause reactive oxygen species and damage the retina potentially. Of course, circadian rhythm can be influenced by the blue light. So when it comes to visual quality with light scatter, dysphotopsias, violet is more important than blue, so or greater impact. Chromatic aberration, similarly, the shorter the wavelength, the higher the impact. Violet's going to be more so than blue. Scotopic vision, blue is actually more important than violet, because we do know that a significant portion of your scotopic vision is dependent on the blue light, so you don't want to filter the blue. Phototoxicity, violet is more impactful than blue, especially in the 410 nanometer range. That's a pretty important value there. That's a kind of a peak where you can have reactive oxygen species formation. In the circadian rhythm, the IP, intrinsic photosensitive retinal ganglion cells, the IPRGCs, tend to absorb in the 460 to 470 range, which is the blue range. So blue is most important. So when you're thinking about how you want to filter, basically you want to filter out the violet and leave the blue. So a red solid line here is the OptiBlue chromophore, or the TECNIS violet light filtering. The two dotted lines are the different powers of the Akersoft chromophore. Now, interestingly, the violet light filter has a very sharp curve, so the IOL power is not going to affect the position of that curve. It's where it is regardless of the power you choose, versus with the Akersoft natural chromophore, it's going to depend on the power of the lens. The thickness of the lens will affect how much filtration. So let's look at these different quantities. Light scatter, you want to filter violet greater than blue. So you look at the red line here, you're filtering out pretty much all the violet. You're leaving all the blue. Chromatic aberration, same thing. Scotopic vision, you're filtering out virtually none of the blue with the violet light filter, whereas the Akersoft filters out, depending on the power, almost half of the blue, about a significant amount of the blue, especially with the higher power lenses. So you're going to affect scotopic vision. Phototoxicity, interestingly, at the 410 nanometer mark, there's zero light going through the TECNIS violet light filter, but there's still up to almost 40% of light going through some of the Akersoft. So even though you're filtering some of the blue that's good, you're still leaving a lot of the violet that needs to be filtered. Similarly, for circadian rhythm, you don't want to filter any of the blue, which is the problem with blue light filtering, is you're going to potentially affect some of the IPRGC cells, your circadian entrainment and functioning there. So again, a lot of this is theoretical. A lot of this is known. Some of it is theoretical, but the idea with a filter is you want to filter what is known to be detrimental, keep what might be beneficial, and be sure not to over filter. Because the thing is, you can always put on some sunglasses, right? So if you want to filter a little more, your outside is bright, put on some sunglasses. You never want to filter something that you ever want to give back. But you want to get rid of as much as what you know is going to be damaging. Reactive oxygen, species formation, chromatic aberration, light scatter. Those are always bad, so you want to filter that. But, how much is scotopic vision? How important is that? Yeah, you want to do that. You want to keep all the blue. What about circadian rhythm? Maybe there's some truth to that, and some people will argue that. I think there's a significant factor. You definitely want to keep the blue. So don't filter if you think it's going to be helpful, but definitely filter what you think is going to be bad. And that's the beauty of the violet light filters. It draws that steep line between violet and blue, keeps the good, filters the bad. So that's dysphotopsias. So visual quality, depth of field dysphotopsias. Again, it all starts with outstanding optics and visual quality. So in conclusion, patients deserve an informed choice of both surgical and non-surgical options. Presbyopia-correction involves a series of compromises. Visual quality, depth of field dysphotopsias, you want to balance those. Now, we have, of course, the TECNIS Symphony and the TECNIS Synergy now, which is available in Canada. It gives you a different balance that you can work with. They offer great options for the idea of personalizing vision, using one in one eye, one in the other eye, or two of each, or two of the other, depending on what the patient is interested in, what they want, what their lifestyle is. You can balance these three things of visual quality, depth of field dysphotopsias with these two different lenses. So again, when it came time to do my mom, as I alluded to earlier, I did her cataract surgery back in 2017. I put 2 Symphony torics in her eyes. I actually did my mother-in-law, which some could argue is a higher risk surgery last year. She ended up with 2 Symphonies as well. And actually my brother's former mother-in-law as well, I did her surgery last year and put 2 Symphonies in her as well. Now, the question is, my dad will be up for surgery probably in the next couple years. So hopefully the TECNIS Synergy will be approved here in the US by then. And I'll probably end up putting 1 Symphony and 1 Synergy in his eyes. So that's all the planned presentation I have for you today. I appreciate you guys, everybody's attention, and hopefully it was educational both for specifics of the TECNIS Synergy, but also for the whole TECNIS family platform of presbyopia-correcting lenses and monofocal lenses and toric lenses. It's a fantastic platform, has great optical properties, and I think it'll do lots of patients very well. Thank you so much. Great, well, I hope you found that presentation helpful, and hopefully you're a little bit excited about the new lens, the TECNIS Synergy IOL coming out. I certainly am. You now have it available in Canada and the US. We still have to wait a little while, but I'm certainly excited to get my hands on it to use it in the wild, so to speak, in the clinical setting. I'm going to answer a few questions right now. These are obviously pre-prepared since I'm recorded here. We can't take live questions, but if you do have questions, feel free to reach out to your J&J rep. If they aren't able to answer it, they'll be happy to direct you to medical affairs and get your questions answered. So just to go through a few here, one is, do you have any published clinical data? I did show some of the data that we presented at ESCRS in Paris last year, some visual outcomes data. That was from the proof of concept study that was done a couple of years ago. Currently, the US PMA FDA pre-market approval trial is still in process, so I can't share any data from that. But hopefully we'll have that at not too distant future, and you'll be able to learn from that as well. There are some ongoing clinical trials or non-regulatory trials going on, so hopefully we'll have some publications. But I can kind of give you my general impressions about some of these additional questions. I can't release official information, but understanding from the principles of the optics and also some of my experience of the patients I implanted, I think we get a pretty good feel for how this lens functions. So one was, how was the evaluation of glare, halos, and starbursts done for Synergy? The studies that we did basically broke into categories. We did a patient-reported outcome, so it was a questionnaire that was uncoached, so they had to read it themselves, answer it themselves. We're described those 3 categories of glare, flare, halos, and starbursts. There's 2 ways of asking questions. One is a non-directed, which basically says, do you have any problems with your vision? And if they say no, they move on to the next question. If they say yes, then we say, oh, is your problem with this? Is it halos? Is it glare? And they can kind of fill. So it's a non-directed questionnaire. Then there's directed questions, which says, how much problems do you have with halos? How much do you have with glare? How much do you have with starbursts? So there's different types of questions, and whenever you see clinical trial results, you're going to ask questions like that. I can tell you from my personal experience when I talk to patients that the night vision symptoms or the nighttime dysphotopsias, they were definitely there, but they were quite tolerable. Now, interestingly, in the proof of concept study, actually the data that I showed you that we presented in Paris was done on the original design of the Synergy lens. It's the ZF-R00. It was a clear lens, so we didn't have the advantage of the violet light filter, and also the lathing of the posterior surface was just the standard lathing method. Since then, and the lens that we're actually putting through the US FDA trials right now has the violet light filter, and it has a slight change in the manufacturing process that results in a better echelette pattern. It's slightly polished, so there's a smoother diffractive surface, so to speak, which we anticipate will improve the night vision symptoms. And I can tell you from the patients that I talked to, just kind of anecdotally, is the amount of starburst that the patients noticed was significantly less. So we do know that's one of the concerns with the Synergy. I mean, the Symphony is talking about the starburst or the little rays of light. I think J&J has certainly addressed that in this lens to reduce those symptoms significantly. Obviously, you're still going to have off-axis light because of the add power, so to speak, or the range of vision that these lenses provide. And that's something that, again, we need to prep the patients for that. And again, in my experience, quite tolerable. What was reported? Spectacle independence, shortcomings of the lenses, patient satisfaction. Again, I can't give specific numbers. I can tell you that from a range of vision, as I said earlier, there isn't a sweet spot to hunt for. They can just hold it here, hold it wherever they want to, and they can see it. I was seeing patients holding things at 25, 30 centimeters, 12 inches in our measurements that patients were just reading up close. People who are low myopes who are happy with their near vision. So again, great vision, again, similar to TMF plus 4 type near vision. And there never was, I didn't have a single patient who said, hey, out here, it's just not quite as sharp. So if you look at the focus curve, there's a little bit of a dip, but when they get out there, the distance kind of affects it. So they perceive it as a continuous range of vision. So that's exactly high quality vision throughout that range. And we also know from benchtop testing is that the image quality, the modulation transfer function is fantastic. So all the testing we do in the lab, in the clinic, is high contrast, well lit, black on white. But I would fully expect in the real world, particularly in dim light situations, reading menus, where the lighting's not quite right, the contrast isn't good, these patients will still have some amazing vision. And my patients were by and large very happy with the amount of near vision and intermediate vision that they got. So would you recommend a TECNIS Symphony in one eye and a Synergy in the other? Why or why not? So that's a good question. In my mind, I think the term personalized vision, at least in the US, has been used. Kind of has slightly different meaning, but the way I like to think about it is whenever I approach a patient is I want to say, hey, what are this patient's visual needs and how can I use the two eyes to achieve that? So whether I put 2 Symphonies in the eyes as I did my mom, whether I do 2 Synergies or potentially one of each. At this point, I'm using the TECNIS multifocal, which is a great lens because I don't have the Synergy available, but I think the Synergy provides that continuous range. So there's a question about, and so for sure, I fully believe that will work very well to be able to have both eyes with great distance vision, have a nice range of vision, a little bit or significantly better near with the Synergy, probably less night vision symptoms with the Symphony to kind of balance that out. I think it'll be a great combination of lenses to use in a certain set of patients. Now, in terms of the chromophore, the violet light filter is just a slight shade. So if you have patients, one eye has a chromophore, one doesn't. If you did this cover on cover, they could probably tell the difference. But quite frankly, a lot of patients, if you just do one eye cataract, their cataract compared to their clear lens, there's a difference. There's plenty of patients who've had an Acrosoft with a chromophore in their previous eye, have done a clear lens. They've done quite well with that. A number of studies have shown that patients will tolerate that. Probably worth mentioning to the patient, there's a slight chromophore, but it's something that's not a real dramatic difference. It does provide, like I said, from a statistical standpoint, a study standpoint, and also we've looked at previous monofocals, just overall a little better quality or tolerance in terms of driving both in daytime and nighttime. So I'm really excited about the addition of the violet light filter in the TECNIS Synergy lens. Hope to see it soon in the other pre-C IOLs or the presbyopia-correcting lens platforms as well. So hopefully that was a helpful discussion. One other thing I do want to mention is, as I alluded to earlier, from a targeting standpoint, we do have that broader range, but it's not quite like the Symphony where you have that flat top plateau of a continuous range of vision. So for a Symphony, if you aim a little minus, you get near vision, you don't drop off that much in distance, you aim a little plus, you have some forgiveness. With the Synergy, you definitely want to aim a little bit plus, because if you end up a little bit minus, that's going to affect your quality of distance vision. And that's one of the challenges, is getting that targeting right. I think with the studies with the A constancy, we learned that through a couple of rounds now, that you do want to aim a little bit plus. And I think if you do that, it's kind of counterintuitive, because we're afraid we might lose that near vision. With the Synergy, you have so much near vision to work with, the patients will do well. So again, other things, correcting astigmatism, taking care of good surgery, looking for ocular surface, all the stuff that you've learned about using presbyopia-correcting lenses still applies here. Do your best surgery, get the best outcomes. The patients will overall do the best and be appreciative for that. So again, hopefully this was a helpful session. Again, it's a pleasure to be able to speak with you regarding the latest family, the newest member of the TECNIS family of lenses. And I look forward to seeing you hopefully in person soon.